experiences and practice patterns. So I polled the audience, no one really gave me much feedback, so we're going to do antibiotics, because that's kind of my bread and butter. If I do start going into the weeds, or let me know, I get excited. I try to add some stuff, more so for nursing, I guess, for like mixtures, what things are compatible with or not, kind of like big ticket items, because I'm not a nurse. I have some stuff for tele too that you'll like want to watch out for some patients, or other like major side effects that are present in the ICU. I'll be going over what I consider maybe the 12 most important antibiotics for the ICU, focusing on some more than others. Okay. A lot of has anyone had a lecture on antibiotics? Has anyone ever heard of antibiotics?
We had a brief, yeah.
Not from me, but like maybe from like in nursing school or something like it. Okay. So a lot of times it's taught based on like pharmacology and how like molecules are, and that's like really boring and not helpful in my opinion. So I'm gonna give like what I think is a clinically relevant talk. So hopefully that's helpful, because this is kind of how I frame antibiotics, especially in the inpatient setting or in the ICU. So my building block where I start is ceftriaxone. Okay. So if I think someone needs antibiotics, I think ceftriaxone, and then I think why or why not, or why not ceftriaxone. All right, and the reason I think that is because it's in the guidelines for standard of care for community-acquired pneumonia, for complicated urinary tract infections, for meningitis, and then for complicated skin and soft tissue infections. So that's most people coming in with an infection. That's most areas of the body. It has good bioavailability, gets most places, has good like strep coverage, which is like the main pneumonia, meningitis bug, has pretty good gram-negative coverage, so think E. coli, your urinary tract infections, intra-abdominal infections, and then it does get MSSA and against strep, which are a lot of your skin bugs. All right. By and large, I'm kind of a 2 grams Q24 will be your standard dosing. You could use 1 gram, but again, if they're sick enough to get in the ICU, you'll probably just use 2. For CNS penetration, it's 2 Q12. So if you see that dose, it's because someone's trying to get into the CNS space. The big thing from a nursing standpoint with ceftriaxone, what is something that you cannot mix it with? Pop quiz. So calcium. So any calcium-containing substances, so big thing is like TPN. So you can't mix ceftriaxone with TPN because it'll precipitate out. So it increases the risk of kidney stones, gallstones, like pancreatic stones. That's bigger with kiddos than with adults, but it's still like a contraindication. But you can mix it with like saline and stuff. Ceftriaxone and a lot of the antibiotics I'll talk about are penicillins or cousin of a penicillin. So main side effects are anaphylaxis. So that's going to be a big one we want to watch out for. Most antibiotics, nausea, vomiting, diarrhea, because we're killing healthy bugs in the back or in the gut. And then some delayed reactions. That's mainly rashes, and you usually see those more like days to a week after starting. And then long-term complications, which we probably won't see too much of in the ICU because usually they get out. But like this gentleman, he's approaching 2 weeks on ceftriaxone, so I start thinking liver injury. You can see like biliary sludging, acalculous, cholecystitis. You can see what we call AIN, which is like an allergic reaction in the kidney. So you can see that your kidney function worsen, although for him he's already on dialysis, so probably not as much of an issue. And then cytopenia, so worsening anemia, thrombocytopenia. So that's a lot of the antibiotics I'm going to talk about. Those are kind of the side effects. Okay, so ceftriaxone, great drug, love it. Once a day dosing, easy to do. You typically give it over 30 minutes? Mm-hmm. Okay. And then from like a coverage standpoint, if I want to broaden, the first thing I think about is cefepime. Okay, so cefepime is essentially ceftriaxone plus pseudomonal coverage. So Pseudomonas is a hardy bug that lives in water in the environment, and that because it's hardy, it is kind of more resistant to things because it kind of has to fight off essentially industrial antibiotics that they use in agriculture. Think about that. So cefepime, the difference between this and ceftriaxone is if someone has like kidney issues, you'll see dosing changes, right? So ceftriaxone you never really change depending on if they're on dialysis or not, liver failure or not, same dose, which is why I love it. It's so nice and easy. Versus cefepime, typically we'll do 2 grams Q8 and then adjust based on kidney function. And then maybe about 10 years ago, they introduced the extended infusion, which I think is what we do here. So a lot of times you'll still do that 30-minute infusion for the load, and then you'll do, 3-4 hour infusion? Is that the protocol here?
This is for cefepime?
Yeah, for cefepime.
I've never seen it
I have
before.
not.
Oh, you guys don't do that here?
Extended.
Okay, you do extended for Zosyn?
Yes.
Okay, yeah. Well, you can do it for cefepime too. So all these penicillin type antibiotics they call it time-dependent killing. If you want to think about it, it's like suppressive fire. It's probably my analogy that I would use. And that the longer that it's infusing and that the longer it's running in your body, like the more it kills. So that's why the extended infusion allows us to give smaller doses, allows for decreased side effects and toxicities, and that's why they've kind of introduced extended infusion. And then in my neck of the woods, we can actually, as an outpatient, do 24-hour continuous infusions, which is like it's essentially like a negative pressure bulb, and it'll just attach to the patient. They switch it out every day. So that's kind of cool.
What do you think we have in transition to that? Because I mean, I have never seen it infused.
The extended infusion?
Yeah, is that a latest? Is that a new thing?
I don't know. So what am I trying to say? So Zosyn was a process improvement project I did as a resident, so that was 2018 for Zosyn. Cefepime, I don't know if I remember as a resident, but out as a fellow, so 2020, 2021. So it was definitely there then. But yeah, it's something I can talk to pharmacy about or whatever. So that's don't worry about that. Okay. Main changes with cefepime, you can mix it with calcium, that's fine. It does have CNS toxicity though, so does lower the seizure threshold, as do some of these other medications. So people with seizure disorders, watch out. And then you can also see like delirium, so it does have like an increased IC delirium. All right, questions on ceftriaxone, cefepime. Cool. All right, then I think Zosyn. All right, so the generic name is piperacillin tazobactam. So piperacillin, like penicillin, the peasants, they've got the same last name. But the brand name is Zosyn, and it's so much easier to say. I'm not, supported by any drug companies. I'm just lazy. Okay, so Zosyn does also cover Pseudomonas, like your cefepime, so more resistant bugs, if you want to think about it that way. But it also covers anaerobes, which is really great for contained infections, so primarily in the abdomen area, because that's also where we just naturally have anaerobes in our body. So if they get in the wrong place, they can get there. This one, you guys do extended infusion, so it's the same idea. The standard dosing is 30 minutes. Now we pretty much only use that dose for the load, and then you do 4 hours. And then again, that allows us to kind of decrease the amount of drug we're giving people. Same side effects. The interesting thing about Zosyn is it does have a decent sodium load, so it's like about 3 milliequivalents for every, I think, gram of piperacillin. So for people with heart failure, you might want to watch out. There is a medication that's a bonus, if you're interested, called Flagyl, or the generic is metronidazole. Okay. And this one also covers anaerobe, so sometimes you might see it in combination with ceftriaxone or cefepime, and it's going to kind of essentially equal Zosyn. Okay. I don't think it really matters too much for coverage. I think it's just kind of provider preference, kind of why you would pick one versus the other. I don't know. There might be a scenario where I have a preference, but I can't really think of one off the top of my head. Metronidazole also has a decent sodium load. Can have some CNS side effects. Usually with long-term use, you can see some neuropathy, some cytopenias. And then it tastes awful. I don't know if anyone here has ever taken metronidazole. But it's a sulfur-based antibiotic, so it tastes like sewage. But it is essentially the same PO as IV, so if someone can swallow or if they've got an NG or OG tube in, there's really no reason they should be on IV unless you're like, I don't know, the doctor argues with the pharmacist and they win, but it probably doesn't matter too much as long as their gut is working, I guess. What else did I mention? Fun fact for people who are zoning out, there is a disulfiram reaction. So essentially, if you take it, you get almost like an allergic reaction to alcohol, where it inactivates one of the enzymes that helps us break down alcohol. So you essentially get drunk very quickly and sick. So they do recommend not drinking until you're off of it for 3 days. There's some not as great data about that, but it is a fun fact. People. Okay, and now we get into antibiotics that we see here in the ICU sometimes, but maybe not all the time. So that's ertapenem, and then meropenem. Okay, so ertapenem. So these medications cover more ESBL or very resistant organisms. Still good gram-negative coverage, still good strep coverage. Ertapenem is nice. It's once a day, 1 gram once a day. So I kind of think of it almost like a super ceftriaxone because it's very easy dosing. Both ceftriaxone and ertapenem are good meds for me to discharge patients on because we can give them in the AIC or whatever we call it here, just once a day. So if you work over in the MSU too or whatever, sometimes you might see a patient come in just for an ertapenem dose or a ceftriaxone dose. Meropenem is a 3 times a day medication. That one technically also has an extended infusion option. Kind of same idea. It's 2 grams Q8. Both of them have very similar side effects to what we've been talking about. So again, allergic reaction, the worst being anaphylaxis, nausea, vomiting, diarrhea, rashes, and then it also can cause, the longer you're on them, it can also cause seizure disorder, CNS toxicity, and then the longer you're on them can cause cytopenias, so low blood cell counts, liver injury, and then kidney injury. But again, that's rare for those. Okay. So and then so these are really good gram-negative strep coverage. They get Zosyn. Maybe doesn't get in the CNS as well, but and then they cover a lot of resistant bugs. Let me see if I have any other notes that I wanted to discuss. Oh yeah, and then as far as dosing, ertapenem is 1 gram. You might split that into 500 milligrams, but the dosing doesn't really change. Meropenem will change based on kidney function as well. That's pretty much it. Okay. Any questions on these guys? Okay. And then, so going back to ceftriaxone, the other thing that I think of is, does this person have MRSA risk factors? Because if they do, or the infection I think they have is in an area where MRSA might be, then I add something called vancomycin. So, vancomycin, I don't have a love-hate relationship with it. So it's really good for MRSA and resistant gram-positive organisms, but it's not like great if you can use something else, if that makes sense. So it will kill strep, but it doesn't kill it as well as ceftriaxone does, if that makes sense. So I really don't like using Vanc unless I have to, if that makes sense. One, because of side effects, but two, also just like how, well, we call it bactericidal it is, but how like good it is at killing bacteria. So with vancomycin, it's kind of tricky to dose, and that's why we have pharmacy do it, and I love them. And that's really the story. So initially you go, initial dosage based off of weight and kidney function, and then you'll be getting troughs, which you guys are very familiar with because you're the ones who draw them for us. Thank you, I appreciate it, and that helps us dose. There's over the past 5 years, there's kind of like a new kid on the block called AUC, or area under the curve, which is essentially just a different way to dose vancomycin, and that's kind of growing. I don't know when it will actually make its way.
Does that entail drawing peaks too? Because we've been starting to draw peaks of troughs.
Oh.
That wasn't a thing in the past.
Maybe then, because so the AUC, they'll get 2 levels, and then from that they can kind of, make a curve, and then they measure the area under that curve. But essentially it allows you to decrease the dose of vancomycin safely enough, and so therefore decreases toxicity and side effects. So it's thought that maybe it's a safer measurement to use. Some fancy EMRs have like it built in, and ours is not, and so they kind of have to do some like fiddling. So I know some pharmacists who do use it, and then some who don't, because we don't like have the software. So it's I don't know. Oh God, this is like entering like things I don't know about. Okay, so vancomycin. You can have anaphylaxis like any other medication, but you can also have this thing called vancomycin infusion syndrome, or vancomycin infusion reaction. Historically it was called red man syndrome, but that's like racist, so we don't say that anymore. But essentially it's almost like a histamine reaction, so you get very red, you get flushed, you can get febrile, you get like, you just feel like jittery and anxious inside. Has anyone ever seen someone get this? Mm-hmm. And so what do you do for it?
Immediately stop it?
Yeah, so you stop it until their symptoms start getting better, and then you can actually just slow the rate of infusion, and hopefully they won't get in the future. If they're stable enough, you can also use things like antihistamines, so Benadryl should help, but slowing the infusion, or stopping and then slowing the infusion, is the main treatment. Otherwise, a big issue is kidney injury, and the problem with that is it's kind of sneaky because it can injure the kidney, but it's also cleared by the kidney. So essentially it's like this downward spiral of it's building up and hurting the kidney, but still building up and hurting the kidney, which is really only an issue if you're not checking. So the more frequent we get labs and we check troughs and stuff, and that's not as much of an issue. But when I use it on the outpatient side, then that's always a concern. Okay. It too can cause cytopenia, so primarily ITP or immune thrombocytopenia, and again that's usually like days, so like 5 to 7 days of therapy is when you'll see that. And then those are kind of the main one. Okay. And so like I said, it's good for MRSA, so I think of that when I want skin and soft tissue infection, if it's a surgical infection, if they're hospitalized a lot, and then like a hospital-acquired infection. So if I think it's a line infection, or if I think it's a ventilator-associated infection or pneumonia or something like that, that's when I use vancomycin. There are two like alternatives to vancomycin, which I'm just going to mention briefly. And I heard from pharmacy here that happens sometimes, that we have to use them if we run out of like the reagent for the vancomycin trough. So those two are linezolid and daptomycin. The other times I use them are if someone is allergic to or can't tolerate vancomycin, if we have difficulty like kind of getting a steady state, either because they're having fluctuating kidney function, or for like our young, healthy, active duty people, they just chew through vancomycin, so you can't actually get a treatment level trough on them. Like they're just subtherapeutic because you have to just use such high doses. So that'd be a time that I use daptomycin as well. And then with going back to vancomycin, the other time is if you're having issues for your dialysis or CRRT patients. So depending on if you're using, so this is like a big difference. So if you're using CVVH versus if you're using CVVHD, you have like different clearance of vancomycin. So it's actually like important for pharmacy to know which they're on. I guess it doesn't, because then you get the trough and you change it from there. But it's like 100-fold. So it's like maybe up to 200% of a normal person's clearance to like 500%, because it just chews it up. So that would be a time that maybe we need to use a different medication. So daptomycin's one. Daptomycin doesn't get into the lungs, so we don't use it for that. And then it can cause like rhabdo, so we'll like follow CKs. It's kind of a big thing, and it can cause an eosinophil, like a pneumonitis as well. Linezolid, I think I've already used twice since being here, but they were both for MSU patients. So linezolid is also a kind of cool medicine because it has a pill form. So we essentially, there are people who needed vancomycin, but I didn't want to send them home on vancomycin, so we can use linezolid. So that'd be another medication we could use if vancomycin's out. Usually the linezolid is like all fine and good until like 2 to 4 weeks, and then they pretty much all get really bad cytopenias, so really bad anemias and low platelets, and then they start getting peripheral neuropathy as well. Okay, but again, usually that's not something you'll see in the ICU. You can see cytopenias sooner than that, but it could be in like the first week, but usually the first 2 weeks are. And then for daptom and linezolid, there's not really any kidney or liver like dosing changes, but they have like increased risk of toxicity with liver and kidney dysfunction. And then for dapto, the same idea that you have to usually increase your dose for people on CRRT. So that's another thing. Okay. So I'll kind of put alternatives here. But these medications are very expensive, and so that's another reason why that vancomycin is kind of like the standard of care, even though it's a bit like old and clunky. Okay. Questions about vancomycin or its alternative medications, or other like things you wanted to touch on?
The linezolid and the daptomycin, they're given together or separate?
They're separate. It's either or. So yeah. So how do we use a lot of dapto for young active duty folks. Usually the people who get the toxicities are kind of your older retirees. And dapto is once a day, and honestly you can give it over 10 minutes to yourself in like a syringe. So it's just you push it as tolerated, because it can be a little like burn. It can burn a little bit. You can slow it down too. So it's really easy to self-administer. For in my experience, it is it has better like kinetics, or is like better at killing the bacteria. So I prefer it unless it's pneumonia, or like here in Guam we don't really do much like IV outpatient antibiotics, so I'm probably going to use a lot more linezolid here than I have. And then I've only really had like one successful patient beyond, maybe two successful patients on linezolid beyond like 2 weeks, and that's usually because we lower the dose or something for like weird infections. Okay. And then a couple other antibiotics that we use here, a reasonable amount. So azithromycin. So azithromycin, doxycycline, and then fluoroquinolone. So the main one being like levofloxacin are the three, and they cover atypical bacteria, and by that they don't have a cell wall, which is really how all of these antibiotics work. Well, maybe not linezolid, but how all these antibiotics work. So if you don't have a cell wall, then it's like useless. They're useless. So those are really the only 3 antibiotics that will work. So pretty much anyone, and the main place you get atypical infections is the lungs. So as part of your CAP treatment, or if they're ending up in the ICU, most of our patients were worried about a pneumonia, or that's on the differential, you'll see either azithromycin or typically doxy or azithromycin thrown on. All those medications also have pill forms and are pretty equivalent bioavailability. So again, if the gut works, you can use it. Azithromycin and levofloxacin both can prolong your QT, so that's something for like tele to watch out for. That's more common in older women, which we see a lot of here, so that'd be important. Levofloxacin is a pretty good antibiotic. It covers, in addition to these, a lot of strep and gram-negatives and Pseudomonas, which we talked about with the other ones. But it has a lot of side effects, so we don't like to use it unless we have to. Those side effects being, QT prolongation, spontaneous aortic aneurysms and ruptures. So that's like that. So that black box warning came out in like the late 2010s, and that's when we saw like a big decrease in fluoroquinolone prescriptions, along with C. diff. It kind of went up in the antibiotics that cause C. diff. So we don't use it as much unless we kind of have to. It can also cause ICU delirium. Can also cause tendon rupture. Those are like the big ones. Okay. And then doxycycline. Doxycycline, and then the other one I was going to talk about, vancomycin. Both those are like very irritating if they extravasate. So those are probably like the 2 big ones that like not like you're trying, but like if the patient's saying it hurts, like maybe something's happening. Doxycycline. Mainly the PO version can cause like a decent like piloesophagitis or irritation. I always recommend taking it with like crackers or something to try and like help. But you always have to watch out for both. Actually, all of those medications, certain foods can kind of like bind them up and decrease absorption. So they recommend like calcium and other like cations, so like your antacids and stuff, if you think about it like that. Or if my outpatients, it's like don't drink your protein shake with your doxy. But here it's like maybe don't give your Ensure with your doxy. Same. Okay. All right, and then the last antibiotic I wanted to okay, and then any question about these? Usually azithro just for like 3 days, so usually we don't give it too long. Doxy we usually do for about a week. Usually it's 100 milligrams twice a day. And then those two don't really have changes in dosing based on like issues with kidney function or whatever. Levofloxacin there is a little bit of changing. But not too much. Oh, and then with Doxy, because of the extravasation and it can be a little like irritating to the vessels, usually it's a slow infusion. You guys probably know that more than I do. You can do like, it's like 1 to 4 hours. I don't know what our practice is here. Okay. Yeah. So if someone's having issues with it, you might just slow the infusion. That's fine. Okay. Any questions about those 3? Okay. You usually won't see them by themselves. They like should be with typically like ceftriaxone. Okay. And the last one's clindamycin. Has anyone seen clindamycin used here, or has anyone given clindamycin? All right. So the main like use in the ICU is for like toxic shock syndrome or like neck fash. So if someone has like a severe skin infection, where we think that there's a component of necrotizing fasciitis or like flesh-eating bacteria is how it's described in pop culture, or toxic shock syndrome, specifically from strep or staph types of bacteria. Clindamycin can be used. It's kind of cool. It like binds up the toxin and helps decrease toxin production. So it's not. It does kill the bacteria too, but it helps prevent like sequelae from that infection and can really help turn the corner if someone's like getting worse. So usually you'll only use that for like 1 to 3 days. You usually don't keep that on for like the course. It's usually just for the beginning when there's a lot of toxin around. Typically we'll use 900 Q8, and then this is one of the highest C. diff, right? Or like it was initially associated with C. diff, and that's why we kind of stopped using it. There is a pill version as well, but usually if you're using it in the ICU, it's in someone who's like way too sick to consider that. So those are the main antibiotics I think you'll see. Has anyone seen like any other antibiotics that you're like, oh, can't believe she didn't talk about this one? Yeah. Usually if we think it's pneumonia, it's like ceftriaxone with either azithro or doxy. Otherwise, like generic sepsis, it's usually vancomycin or vancomycin. If it's intra-abdominal, maybe you'll see a ceftriaxone flagellar metronidazole. Yeah. Cool. Was that helpful? Okay. This was also my first time doing this, so you don't have to lie to me, or else you're gonna keep getting these lectures like this. So if you is there anything else for like next time that you think would be like more helpful, useful, relevant?